right. Presume you guys can hear me okay. So last week we talked about cutaneous T cell lymphomas. Today we're going to talk about cutaneous, so we are recording this, I want to make sure, cutaneous B cell lymphomas. And of the two entities, like I said last time, the T cell lymphomas are way more important than the B cell lymphomas as far as the number of lesions that we see. We really don't see that many cutaneous B cell lymphomas. And the vast majority of the ones that occur in the skin, probably the most important thing for you as a dermatologist is that these tend to be very low grade and very benign, if you will. They don't really tend to spread throughout the body. They tend to be localized to the skin. They can sometimes be treated with even surgical excision, sometimes even intralesional steroids. And if you go back in time, years ago, before we had immunoperoxidase stains and gene studies, we used to call, probably the majority of these were called benign pseudolymphomas. And in fact, there was one lesion that used to occur on the back. It probably really was now today be probably called marginal zone lymphoma. Used to be called semi-malignant lymphoma or immunocytoma, and just had a very low-grade behavior, 99% 5-year survival, not 100% 5-year survival, because occasionally one of these will kind of break through and then the patients will get involved in the lymph nodes or whatever. But the vast majority of these are benign. And so you don't want these to get in the hands of an oncologist who doesn't understand it and thinks they're dealing with a systemic lymphoma and treats the patient with chemo and they're just too aggressive. So you have to understand, as the gatekeeper, if you will, of these B cell lymphomas, that they don't really need to be seen by an oncologist and treated aggressively. They can be seen maybe as an oncologist sort of as a baseline if you want to make sure they don't have any lymphadenopathy, and maybe they're followed, but the vast majority of these are just benign. So let's take a look at some things here. So the first thing we want to obviously be able to do is distinguish between benign and malignant. And, these generally, they kind of look like pink papules, nodules. Sometimes they're not really usually gargantuan lesions, or they're often relatively small. And they will sometimes come in as rule out basal cell carcinoma or insect bite or things like that. They're not really thought to be any kind of malignancy. And here's an example of one of those. So this is a shave biopsy. It's got all this pseudoepitheliomatous hyperplasia up here, and it's got this infiltrate of small, typical appearing lymphocytes. There's some admixed histiocytes, and then there's some eosinophils admixed in here. So this is just what we would call maybe a pseudolymphomatous inflammatory reaction. It's not a classic pseudolymphoma. If you really see a nice example of pseudolymphoma, it's usually a nodular infiltrate of small lymphocytes with obvious germinal centers with eosinophils. It's often wedge-shaped. They often get precipitated by an arthropod salt reaction, or maybe even by allergic contact dermatitis or nodular scabies. Those are all things that can kind of give you a pseudolymphoma morphology. And so this is the kind of thing we see when we just see kind of a benign inflammatory pseudolymphomatous reaction. Sometimes we see this in patients that have benign lichenoid keratoses. This lesion might have been a seborrheic keratosis or a wart or something like that got inflamed. But this is just benign reactive B cell lymphoid hyperplasia. No cancer here, nothing to worry about. We probably wouldn't send this off for any kind of study or be concerned about it or anything like that. And the clinical is obviously important in these lesions too. You want to make sure that you get good clinical information. Sometimes we'll see a lesion that's got a very dense nodular infiltrate. It comes to maybe rule out basal cell carcinoma in an older person, and they may have a little area of metastatic chronic lymphocytic leukemia that populates the area. We see that on occasion also. So we'll sometimes call that to the attention of the dermatologist if we see that. Now here's a different biopsy and different lesion. This one's got again, it's a shave biopsy, but you can see even a low magnification. This has a different pattern. It's more heavily, it's dark. The cells are, obviously when you see something at low magnification, cells look kind of black or dark, you think that they're going to be lymphocytes. And this is a very nice example of this type of B cell lymphoma pattern. Now, the clinician was probably not thinking of a lymphoma here. They did a kind of a deep saucerization biopsy. It would have been nice if they would have done a deep incisional or a punch biopsy, because we would see just how deep this thing goes. But notice the pattern here, this sort of teardrop shaped aggregations of these lymphocytes here at low magnification. That's very, very characteristic of these cutaneous B cell lymphomas. They're not wedge shaped like a pseudolymphoma. They tend to give you these kind of wax dripping off of the candle kind of morphology. And that's actually pretty characteristic. Sometimes they can be more diffuse and involve the entire dermis, especially when you're getting into some of these more aggressive, poorly differentiated B cell lymphomas we'll talk about a little bit later on. But when you see these well-differentiated marginal zone follicle center cell lymphomas like this, this is kind of the pattern that we see. And this one was basically signed out just as a malignant B cell lymphoma. When I look at this pattern, I really start thinking of either marginal zone lymphoma or maybe a follicle center cell lymphoma. And you can see that it does have some pallor centrally. So there's got some cells that are attempting, if you will, to form a germinal center. And notice that some of these pale cells are they're not in the center of the little nodular aggregation here. So one of the things we talk about in follicle center cell lymphoma, and we'll talk about that in a couple more slides, is so-called inside out germinal centers. So normally in a pseudolymphoma, you get a dense nodular aggregation with the small lymphocytes at the periphery, and then you get the nice pale central areas, the centrocytes and the centroblasts and the other cells of the germinal center in the center of that. So that's a classic, if you just look at a lymph node, that's classically what you see. And if you look at a pseudolymphoma, that's what you see. If you start seeing those cells that are at the periphery and they're breaking through the center, again, think in terms of so-called outside-in germinal center-like morphology. And these are poorly formed follicles, and that favors something like a neoplastic follicle center cell proliferation. And so that would be more commonly seen in a follicle center cell lymphoma. And I would probably, if I were seeing this for the first time, that would be my number one diagnosis of this lesion. I would favor that this might be a follicle center cell lymphoma, and then we would work it up with additional studies. So if you see germinal center cells that aren't confined to the center and they're moving out to the periphery, think about follicle center cell lymphoma. And the other thing about B cell lymphomas versus T cell lymphomas, we talked about last week that T cells tend to be epidermis, you get epidermotropism, or you get the involvement of the fat sort of in a diffuse lobular paniculitis-like pattern, which is seen in the fat. B cell lymphomas don't tend to do that as much. They tend to either give you a diffuse involvement with the dermis, especially in these poorly differentiated B cell, large B cell lymphomas. We'll talk about the diffuse pattern, or they'll give you this pattern and it spares the epidermis. So T cell likes epithelium, B cell doesn't like epithelium. And T cell sometimes likes fat. B cell, if it gets in the fat, it's just kind of getting there because it gets large. It's not really homing to the subcutaneous fat. So that's one of the things, and I'm a morphologist. I really think that we've sort of gotten away from morphology in the lymphoma category. Unfortunately, everybody's just really focusing on these stains now, which, we need the stains and that's important. But if you see this pattern and this teardrop shape like this, think about a B cell lymphoma. It's not wedge shaped like a pseudolymphoma, and you don't get the germinal centers where you got the nice lymphocytes at the periphery. They're kind of spreading outside of it. These are all morphologic findings at low power pattern diagnosis. Think of a B cell lymphoma, okay? And then here is a stain, okay? And one of the things that we look for in these cutaneous lymphomas, the B cell lymphomas will stain positive with B cell markers. So the classic one that we use is CD20. And we'll talk about, we get into some of the other lymphomas here in a minute, looking at BCL6 in a second. But that's one that if you look at these germinal centers, if you were to stain this with BCL6, it would be strongly positive. And CD10 is also positive in those as well. I don't really think you need CD10. I don't find it to be that useful. So if I were looking at this lesion with this morphology, we stained it with BCL6 and it was positive, To me, that's going to be follicle center cell lymphoma. And I think I can do that with those stains. I don't need 20 stains. I don't need a panel of 6 or 8 stains. I can save the patient money just by doing these stains. And it's targeted and coupled with the morphology. You can make a diagnosis of a follicle center cell lymphoma if you were doing that additional, just a couple of stains on that. Now, BCL2, people talk about that being more positively seen, and that can kind of help you with distinguishing benign and malignant as well. The one problem with BCL2 is that it stains T cells. And these cells, again, I was taught when I was trained that, basically if it's CD20 positive, then it's B cell lymphoma, it's CD3 positive, then it's a T cell lymphoma. And then they had this entity called T cell rich B cell lymphoma. Every one of these has got T cells in it too. So throw that out the window. So if we were to do a CD3 stain here, it would be positive also. So when you see the thing that it really wouldn't have is this very dense nodular aggregation of CD20 staining. So when you see the strong CD20 staining with the CD3 cells in there as well, that still could be a B cell lymphoma. And if you do the BCL6 stain and it's positive in these germinal center-like areas, I don't really even waste the money on a BCL2. I just say this is almost certainly going to be a follicle center cell lymphoma, given this morphology, given the clinical, and given this sort of outside-in germinal center formation. To me, that's follicle center cell lymphoma, and you can treat the patient conservatively, and obviously make sure they don't have lesions elsewhere. But we don't use CD10 here very frequently. Don't use BCL2 very frequently. I just don't think you really need it in a skin lymphoma like this. So this is, even though it's called a malignant B cell lymphoma, to me, this is almost certainly a follicle center cell lymphoma in this case. Okay, we'll talk about another one of those in a minute. Now, here's another example. Again, cutaneous B cell lymphoma. Notice it's got that kind of teardrop type morphology here, elongated lymphoid aggregations. Okay, and then some of them are beginning to kind of blend together. This one's, but this pattern, very characteristic of the follicle center cell lymphoma and also of marginal zone lymphoma. And in this case, we don't really have the germinal center formation. We just got these cells that are kind of pale and kind of diffuse. And as we go to higher magnification, you can see a lot of these cells either are plasma cells or they have a plasmacytoid morphology to them. So if you see what looks like this sort of nodular pattern with these kind of teardrop shaped aggregations, and then you see plasma cells, plasmacytoid cells, that's classic for marginal zone lymphoma. And here, you don't need to just throw a panel of BCL6, BCL2, CD, all these things. You look here for light chain restriction. So if we're going to see this pattern with a fair number of plasma cells, the next stain we're going to order here is kappa and lambda, looking for light chain restriction. And if it's positive for one of those two, and it doesn't stain, say, with lambda, it does with kappa, you got a slam dunk diagnosis of marginal zone lymphoma in this situation. So to me, that's a really very helpful pattern. So look at the pattern, look for the type of cells. Notice this doesn't have the inside out germinal center formation like the last one we just talked about. This is kind of more of just a diffuse infiltrate of these cells, but having this kind of overall kind of nodular teardrop shaped pattern with no involvement in the epidermis. And then you look at higher magnification, see the plasma cells, the plasmacytoid cells. That's marginal zone lymphoma until proven otherwise. And then you can prove it, or you can establish it with the monotypic light chain restriction. Now, one word of caution: occasionally get one of these lesions where you don't get evidence of that light chain restriction on the stains, and you may have to do another biopsy, another lesion. Suddenly you do see it. So when it's present, and then it's obvious. If it's maybe some expression of lambda and some of kappa, but more of one or the other, it's not 100%, but it still can be seen in these lesions. And sometimes you'll biopsy multiple areas, and then you'll see classic fully light chain restricted areas. And then you can make a definitive diagnosis of marginal zone lymphoma. And the good news about this lesion also, this is a lesion years ago that used to be called semi-malignant lymphoma, immunocytoma. 99% 5-year survival. These patients do beautifully, very well. Occasionally they'll break through, and occasionally these patients may have Waldenstrom's macroglobulinemia or maybe associated with myeloma in some of these cases, but that's relatively uncommon. Most of these stay in the skin. They don't do anything bad for the patient, and they have a good long-term prognosis. These are the kind of lesions that have been reported in Europe, especially in patients that have Borrelia-associated lymphomas. If they get a lymphoma, it's generally this type of lymphoma. It's not a diffuse large B cell lymphoma. It's usually not follicle center cell. It's usually this kind of marginal zone lymphoma when they get that. And, in this country, we generally call most of those pseudolymphomas, but now I think with demonstrating light chain restriction and demonstrating clonality with B cell genotypic evaluation, looking for gene rearrangements in there, I think we've sort of classified these as a lymphoma, but they're really very, very low grade, and that's important. And so the EO TRC group, whatever the acronym is, the lymphoma working group, they go every few years and they look at these lesions and then they decide how they're going to classify them. And I would think if I were sitting in that panel, I would push to get this kind of lesion declassified as a lymphoma and more as a reactive process that just sometimes has light chain restriction in there, because they just have such a good prognosis. And they downgraded the CD4 small to medium-sized lymphoproliferative disorder from a lymphoma to a disorder, but that's got a 60 to 80% chance of getting lesions elsewhere. So that's a more aggressive lesion that they downgraded. Here you've got a less aggressive lesion that they've kept as a lymphoma. So it sort of doesn't make a lot of sense to me. But in any event, just realize that it's a very low-grade lesion, and this is not the kind of lesion you want to get the patient worked up by an oncologist, and no chemotherapy or anything like that should be done. Now here is an example of a lesion. This is actually a patient that had basal cell carcinoma in some of these areas here, but also had a very dense infiltrate of these lymphoid cells in it. Okay, so let's scroll around here. Here's the basal cell, okay, basal cell carcinoma. And then down at the bottom over in another area, you got these nodular aggregations of these lymphocytes in here. What are they doing here? Why is this going on? Is the basal cell just really an inflamed basal cell carcinoma? It's got all this inflammatory infiltrate that's occurring secondarily to it. Well, in this case, it was a patient that had known chronic lymphocytic leukemia, and the leukemia just happened to colonize the basal cell. And so when they excised the basal cell, we saw the leukemic infiltrate in association with the basal cell carcinoma. So this happens not altogether infrequently. And so you sort of have to have an index of suspicion. And if you see this histologically, call it to the attention of your clinician and say, hey, there's this dense nodular infiltrate similar to like what we see in patients that have CLL. Does your patient have known CLL? Sometimes they'll say no, and then they'll go back and work the patient up, and you make the diagnosis based on the biopsy, coincidentally. And then in other cases, they say, oh yeah, they do. They've had it for 20 years. And I just forgot to tell you on the pathology rec slip, but basically we do see this pattern. And I'd say, it's not super common, but it's not super uncommon either. It's enough that it's worth at least calling your attention. So this is not a primary lymphoma occurring in the skin. This is basically a secondary involvement of the skin from a patient that had a known CLL associated with just happened to have a basal cell. Now, patients that have CLL, they can also get other forms of lymphoma in their skin. If you, in their lymph nodes, for example, they can get other types of malignant lymphoma associated with a CLL. So they generally tend to get worked up for that. And this also, if you're going to stain this, will stain really strongly positive for CD5. So that's a marker that we really look for when we're looking for a cutaneous CLL. So CD5 is very common in that situation. Okay, let's take a look at this next case. And if I were going to ask you this as an unknown now, you've already seen one of these, what would be your number one diagnosis looking at it at low magnification? And the reason I love this, and sadly enough, no one's really doing this in dermatopathology these days. They're just all focused so heavily on these stupid stains. Just look at this at low magnification. It's got a beautiful morphology here of these elongated teardrop-shaped lymphoid aggregates that you can see at low magnification. These are lymphocytes. You don't need to go to higher magnification. And notice what it looks very similar to that first case that I showed you. It's dark and it's pale. And normally, if this were a pseudolymphoma, the pale should be in the center, surrounded by dark, It should be wedge shaped. Notice this isn't wedge shaped. It goes really all the way down to the subcutaneous fat. So it's really a deep involvement, and it's got these different these aggregations vary in size and shape, but they all have this elongated sort of teardrop shaped morphology. So if I were to ask you the number one diagnosis here, I would hope you would say, well, it looks very much like that follicle center cell lymphoma that you showed us at the beginning. And as you go to higher magnification, lo and behold, that's exactly what this is. And if we were to stain this with that BCL6 marker, it's got this inside out pattern of the germinal center formation. So these germinal centers are really not well formed and surrounded by lymphocytes. They're just kind of diffuse and spreading all the way through these individual aggregations. So you can stain this. Go ahead, put some stains on it. But if I just saw this pattern, I would really strongly favor the diagnosis of follicle center cell lymphoma. And if we were in Africa looking at this, where we didn't have a lot of special stains, that's my diagnosis. I'm going to say, guys, this is follicle center cell lymphoma based on this. And sorry, we can't confirm it with all these stains, and we're going to just call it that based on this. And if we were in Africa, we might not even get a biopsy. But given the fact that we do have a biopsy and it has this pattern, it's got the beautiful classic findings of follicle center cell lymphoma, you could confirm it with your CD10 positive staining, which would stain these areas. BCL6 would be staining it. BCL2, you'd stain the T cell areas. And so this would be a nice example. I mean, it's a beautiful example of follicle center cell lymphoma. So I really want you to picture in your mind, close your eyes and see this pattern here. And so when you look at it at low magnification, when you're in a board examination, you can say, that's almost certainly going to be follicle center cell lymphoma. And then you go to higher magnification, you're going to see the inside out germinal centers. And then you're going to do this, if they show you some stains, BCL6, CD10 positive, then you're going to say, hey, this is follicle center cell lymphoma. It's a B cell lymphoma, low grade. Our patient's not going to do badly, and they're going to probably live happily ever after with this thing. And they rarely are going to get secondary involvement. So one other thing I will mention is that notice that this has got a fair number of the germinal center cells, the pale cells. It's certainly not the predominant cell. Whoops, didn't mean to do that. It's not the predominant cell type, but you can get, if you look at these, when they get into the lymph nodes, they can either be sheets of these paler germinal center cells versus the small lymphocyte cells. So they talk about, there's some types that they talk about follicle center cell predominant, and then the small lymphocyte predominant follicle center cell. So remember, the lymphocytic follicle is comprised of the small lymphocytes, but it's also comprised of the germinal center cells, and then post-germinal center cells, centroblasts, centrocytes. Some of those cells also are involved in that. So you can either get most of those, so they can be really mostly clear type pale cells, or mostly the small cells, and they're both follicle center cell lymphomas. So there's two types, especially when you're dealing with the cells in the actual lymph node. But in the skin, this is a beautiful classic example of this. Okay, now this is a super rare entity. We don't really see this very commonly, but I want to point it out to you because it is something of importance. So notice here, we don't have a nodular infiltrate of a lot of lymphocytes here. We basically got something that almost looks like a perivascular dermatitis. And as you go to higher magnification, you start looking inside these lesions, these cells here, and you got some of these blood vessels are kind of thrombosed a little bit here. But this is a blood vessel, and there are these atypical lymphoid cells inside the lumen of these blood vessels that are chocking it. It's chock full of these atypical lymphoid cells that's causing a secondary thrombosis of the blood vessels. So what's going on here? This is an intravascular B cell lymphoma. Intravascular B cell lymphoma. Very rare entity. And these patients, just like, remember last week, we talked about the CD12345 lymphoma, the blastic plasmacytoid dendritic cell neoplasm lymphoma, which isn't really a lymphoma, but it's a neoplasm that's comprised of those CD123 positive cells. That can look like a bruise. This lesion also can look like a bruise. So these patients come in with this kind of dusky, bruise-like morphology. You say, gosh, this looks like maybe livedoreticularis, or it looks like kind of a bruise-like morphology to it. It's not going away. Patients maybe doesn't feel well. Maybe they've lost weight. Maybe they've got some B symptoms. So instead of just brushing that off as the patient's just got a bruise or whatever, remember to take a biopsy. And when you do, this is what it looks like. And notice these cells are so thrombosed here, these vessels are so thrombosed, the epidermis has gotten necrotic and it's separated away. So this has resulted in ischemic necrosis of the epidermis, and it's due to intravascular cutaneous B cell lymphoma. And these patients, when they have this, this is not confined to the skin. This is really a manifestation of a systemic lymphoma. And as opposed to follicle center cell lymphoma and marginal zone lymphoma that have excellent prognoses, this lesion does not have a good prognosis. This has got a bad prognosis. So you really want to, this is the one you want to make sure that you don't miss. So just remember, patients come in with funny bruises that don't go away, and they have symptoms associated with them. You should be thinking about the possibility of other things. Think about this disease. Think about that CD1, 2, 3, 4, 5, 6 tumor. Think about the possibility of calciphylaxis. Think about DIC, all these kind of things. So when the skin gets purple, it's generally not a good thing. And we actually do have some immunoperoxidase stains of this lesion. And this is the control, which is kind of cool to look at. So this is CD20. So notice this is staining B cells here. So that's your lymph node. That's your normal control. And notice these are little germinal centers, and these are little lymphoid aggregates here, staining positive CD20. This is the BCL, so this is CD20 stain of these B cells sitting inside these blood vessels. Okay, so these are B cells circulating here, chocking these blood vessels full. Here's one for CD5, which is pretty much negative. Maybe a few cells are positive, but personally not very strongly positive. This is BCL2. Okay, so let's look at the normal lymph node over here. So this is the T cell area, most likely around the germinal center. Notice that it's not staining the germinal center here. So this is a BCL2 that's highlighting these cells over here, probably some of the B cells also. But then let's look at the lymphoma part, which is over here. And it's pretty much negative. So we're not really getting, they got a few cells that are positive, but not really super strong, but it's positive. So the BCL2 is positive there. So it's staining those neoplastic B cells there as well. This is BCL6. Okay, so beautiful example of the follicle. So just like the BCL6 that would stain the follicle center cell lymphoma, here's what it stains normally in a normal germinal center over here. So it's a nice example of that. And then let's look at the neoplasm, and basically you're getting a few cells that are positive inside the lymphoid cells, inside the blood vessels here too. So it's staining positively with mostly BCL2, but also with BCL6. And then the last marker here is MUM1. So now MUM1 is a post-germinal center cell B cell. So look, here's the germinal center. So that's going to be staining positive BCL6. And then MUM1 stains the cells when they got a little bit more mature. They're staining these cells that are now floating out towards the periphery of the marginal area of the lymph node. So these are MUM1 positive cells here. There's some over here as well. And those are seen in some of the other neoplasms, like the diffuse large B cell lymphoma that we'll talk about in a minute. And this cell, because it's staining kind of a later cell in the lymphoid lymphogenesis, if you will, and forming the lymphocytes, it stains. We saw some staining in the BCL2, so it's got some staining with some earlier markers, but it's also got some of these cells with the post-germinal center marker as well. So that's a marker that you're dealing with kind of a more aggressive tumor if it's got this marker as well as the other one on it. So this was staining with MUM1 and BCL2, a little bit with BCL6, but strong positive staining with CD20. So that's this intravascular B cell lymphoma. So that's a nice way to see the normal cells that are staining on the lymph node, and the fact that these lymphomas express some of these same markers. And if you put the panel of these together, it can kind of help you make the diagnosis. In this case here, in my opinion, when you see CD20 and you got these blood vessels that are chock full of this stuff, you don't really need all these other markers. And what else is going to give you that bruise-like morphology with B cells sitting inside blood vessels and causing thrombosis. You can do these other stains, but who cares? Unless you just want to kind of stain what you already know a different color, you know pretty well it's got to be that entity when it's got that pattern and it's got that staining with CD20. Nothing else really will do that. Okay, so this lesion's our last one we're going to look at today. Notice here, does this give you that same pattern that we talked about before with those nice teardrop-shaped morphology here? No, we've lost that. We've got these individual aggregations here now that have basically coalesced. So we've got more of a diffuse sheet-like pattern. We still have a little bit of some of the nodularity down here at the bottom, but now we've got a sheet-like growth pattern. Okay, and once you see that, that's a bad finding. You know, whenever you see loss of the cells to be able to form these little aggregations, they're no longer a very good ability to form germinal centers. So it's just a sign of poor differentiation and the lesion is becoming more diffuse. So again, we look at criteria for benign versus malignant: large, asymmetrical, poorly circumscribed, diffuse sheet-like growth pattern. Those are all things we look for in malignancy. And as we go to higher magnification, you see these cells are small, they're blue, poorly differentiated. So something like this, you would think, well, gosh, you know, this could maybe be a poorly differentiated lymphoma. It could even possibly be a neuroendocrine carcinoma. So in the differential diagnosis, you have to throw in there other things that are poorly differentiated, basophilic, and blue. And the differential diagnosis between a lymphoma and Merkel cell carcinoma, or maybe a Wilms tumor, or a childhood brional rhabdomyosarcoma, you know, some of those kind of things is different. So you want to make sure that you can tell them apart. So that's where you might want to do some immunoperoxidase stains to rule those out. In a case like this, where you've got some cells here, there might be plasmacytoid or whatever, you might favor the diagnosis of lymphoma. But when you see this sheet-like pattern, now you're dealing with something that's not going to have a very good prognosis. So notice also that it's sparing the epidermis. So it's still a B cell pattern. So no epidermotropism. It's got a little grin zone here. And higher magnification, again, you can see these just very poorly differentiated basophilic cells with nucleoli in there. So probably going to be more likely to be lymphoid than like neuroendocrine. But this is one you probably would want to stain. And this is the typical pattern that we see with this diffuse large B cell lymphoma, often seen on the leg of older individuals. In fact, it's been called diffuse large B cell lymphoma of the leg because that's the most common location. They don't have to occur on the leg. They can occur in other parts of the body as well, but the leg is a very common location. And it's very diffuse in the sheet-like pattern with these cells can get large and almost histiocytoid. They're mitotic figures here. They're striking pleomorphism. And so when you stain this up, this first one is a CD20. So here's the background normal lymph node. And notice the strong positive staining here. These will be the T cell areas up here. Here's the B cell area. And you've got admixed T cells and B cells in this area. Notice they're not all staining positively for CD20. And then there's the germinal center. So T cell area, B cell area, germinal center. So that's your normal background lymph node. And then let's look at the lymphoma and notice it's just diffusely strongly positive for CD20. So again, that confirms the B cell nature of the lesion. And this, we talked about the MUM1 stain. Okay, well, here's the control from MUM1 over here. And notice that this is very strongly positive for MUM1 here. So remember, if you're looking at a germinal center, you get when you form a germinal center, you get the primitive early germinal center cells that are forming, and those can stain positive with BCL6 and some with mostly BCL6. And then when they kind of become more mature, a little bit later on, when they're moving towards the outer part of the germinal center into the more paracortical areas, then you start staining with MUM1. So here we got a strong positive stain for MUM1 here, and that kind of goes along with this diffuse, poorly differentiated, large B cell lymphoma. So those are strongly positive for MUM1. Now, again, if I look at this morphologically and I see it's CD20 positive, I don't think I've really ever ordered a MUM1 very frequently in my career because I can look at it, make the diagnosis, and move on to the next case. I don't really think you can do this if you want to confirm it, but basically, if you look at it with that pattern and that morphology and CD20, what else is going to do that? Really nothing else. So it's pretty much specific for it, but the mum one just comes another stain that kind of gives you that information. And this is a key 67. All this stain does is just says, wow, these cells are proliferating and they're large, they're mitotically and metabolically active. Well, if you look at it from an H&E perspective, yeah, you know they're going to be metabolically and mitotically active, and it's probably going to be something that could kill the patient. So I don't order this stain very frequently either. I don't think it adds a lot other than just kind of tells you that, wow, these cells are proliferating. They're growing. They're potentially going to harm the patient. And so I don't find a lot of utility for it, but it just kind of confirms what you already know. And so if you do a key 67 of the germinal sitter, surprise, it's those cells are in mitosis. They're growing. They're forming T cells. They're forming B cells. They're proliferating. So yeah, it's positive. And this was a tonsil, and the key 67 is positive. The basal cells of the tonsillar epithelium, because they're growing too. So all it tells you is the cells are growing. They're mitotically active. They're metabolically active. It doesn't say anything about benign versus malignant. So I don't know. I'm kind of a nihilist on that stain, but it does show that it's proliferating and it's associated with a bad prognosis. So that's an overview of most of the B cell lymphomas. The most important teaching points. These clinically can simulate basal cell carcinomas, bug bites, pseudolymphomas. They usually, especially things like follicle center cell and marginal zone, they have very, very good prognosis. You don't want to get those over-treated by chemotherapy. Make sure if you do send those to an oncologist that they don't over-treat the patient. So again, we'll have another session next week. Don't remember what the topic is, but basically from the board perspective, they're mainly going to want you to know probably about these lesions we've talked about today. They're not going to get into a lot of esoteric things and stains and whatnot. I think if you know generally some of these just basic stains, know about these large B cell lymphomas of the legs, that those are aggressive and then the others are benign, that's really 90% of what you need to know for cutaneous B cell lymphoma for the board examination. Okay, thanks a lot, and we will see everybody next week, and have a great week. Stay warm.